This presentation is about foreign body ingestion in the pediatric population. So you're seeing an 18-month-old girl in the emergency room with her grandmother. The grandmother reports that she saw the child swallow a battery from a watch that the child's older brother was playing with. And you're seeing the patient is smiling, is in no distress, but the grandmother lets you know that the patient has refused to eat anything since then. So what are your next steps? And foreign body ingestion in children, we want to first of all rule out that the child is not in any respiratory distress or in any distress before we go ahead sitting down chatting with the grandmother to get a better history. Okay. If the child is in respiratory distress, then we want to take care of that first, stabilize the child, and then go ahead into what I'm about to talk about. So the child is like this, like our 18-month-old girl that presented to us, who's smiling, is pretty much stable, but the only thing is that the child hasn't eaten anything since then. And we want to get a good history. We want to know when the child ingested the object, and we want to know the size of the object. We want to know if the child had any symptoms ever since the ingestion of the object. And if possible, if there's even a replica of the object, that'll be very helpful. And as well as your, normal history that you want to get, allergies, um, immunization records, and the, background information. But as far as a focused history, we want to get all those important things about the object, the timing, and any symptoms that occurred since the patient swallowed the object. Afterwards, we're going to do a physical exam, check the vitals of the patient. Is the patient respiratory rate normal? Is the patient tachycardic? Any fevers? And then we can go ahead and do a head, ears, eyes, and neck and throat exam, right? So we want to take a look at the orifices. We know that the child put in something in the throat. That's what the grandmother saw, but it wouldn't hurt since we're looking through the throat anyways to check the ears if anything was put down there as well. Then we can listen to the heart and lungs, and then do an abdominal exam for the patient. And then just see the general appearance of the patient. Is the patient drooling? Is the patient breathing heavily or breathing with a lot of respiratory effort? Or is the patient smiling, playing, and otherwise asymptomatic? When we suspect a foreign body ingestion in a child, and after we've done a history to know the object that was ingested, the timing, and if the patient presented with any symptoms, we want to go ahead and do some imaging, and specifically biplane radiographs. So we want to do an X-ray in this case, an anterior posterior X-ray, as well as a lateral X-ray of the neck, chest, and abdomen. So a CT isn't always necessary, okay? If the child isn't showing any symptoms and the object that the child swallowed is less than about 2 centimeters and it's not sharp, then we no need to do a CT. But a biplane radiograph X-ray of the neck, chest, and abdomen is important. So after we do that and we locate where the object is, hopefully it's in the esophagus. If it is, and if the object has certain features, then that can make us have to do an endoscopy, okay? But in what patients do we have to do an endoscopy for? We do endoscopies in patients who have some features. For example, if the object the patient swallowed is sharp, or if it's a magnet, or if it's a battery. Okay, those are risky objects we don't want to leave there in the patient's GI tract, even though the patient is asymptomatic. So if there's any of that, or if there's any respiratory symptoms, or the patient can't swallow, refusing feeds and is drooling, or if the object has been swallowed for more than 24 hours, or we have no idea when the patient actually swallowed the object, then we want to do an endoscopy to find the object and take the object out. This is not all patients we have to do an endoscopy for. We can just observe a patient and do repeated x-rays to kind of follow the object if the object is not high risk and is not sharp. So for example, if the object is a coin, right? And the patient is doing fine, baby's not crying, baby's eating well, basically as if nothing ever happened, then we can just follow the coin basically through doing serial x-rays. And then if the coin is moving down, then yeah, we expect the coin to just go down the GI tract and the baby will poop it out someday. If the coin isn't moving, then we can go ahead and do an endoscopy to take it out. So in summary, when we suspect a foreign body ingestion in a child, what the child swallowed and when the child swallowed it matters. So you want to get that in the history. Now, if there are alarming features to what the child swallowed, so if the thing is a battery or it's a magnet or it's a sharp object, then we want to go ahead and stabilize the patient. First of all, if the patient needs stabilization, and then endoscopically remove the object. If there are no alarming features, see the patient just swallowed a coin and they're not showing alarming symptoms like drooling or respiratory distress, then we can just follow the object with repeated x-rays. And then hopefully the object just goes down the GI tract and the child poops it out. And then if the object doesn't move as we're trying to follow with the serial x-rays, then we can go ahead and do an endoscopy.